Any idea? Any remembrance?
I have Veruciform xanthoma as the last slide.
What is that?
Veruciform xanthoma as the last.
Oh, okay. So we okay, now I remember. So I just didn't talk about the granulomatous mimic. So we did talk about Langerhans cell, non-Langerhans cell, xanthogranuloma, reticulohistiocytoma. I taught you about Rosai-Dorfman disease and all that fancy stuff. And we ended with, so we just didn't talk about the mimickers of the xanthomatous process. So I didn't talk about a hibernoma. Okay. I didn't talk about an AFX, did I? No. Okay. So good. So what was basically left, yes, that's why it was 15 minutes or even less than that, is that there are some entities which you should remember which can mimic granulomatous process. So AFX is like one of the classic among them. This tumor mimics a granulomatous process because it can have a preponderance of the giant cells, right? But the giant cells are very ugly. They are truly atypical, and the tumor is very pleomorphic by itself. So you have atypical mitoses, you have this fascicular spindle cell proliferation. The architecture of the tumor in terms of the way that it abuts the epidermis and arises from it is also really, really classic for it. So even though this tumor is fibrohistiocytic in derivation, it's a malignant spindle cell neoplasm, which is a diagnosis of exclusion. And we'll talk about AFXs when we talk about non-melanoma skin cancers. But remember that this can sometimes occasionally mimic a granulomatous tumor. The location, the sun damage is very classic for this tumor. The next common mimicker is this particular entity, and that would be not this one, sorry, it would be this one as well. Okay, so is a granular cell tumor. So the granular cell tumor is Schwannian in origin. It consists of packets and nests of cells which will have eosinophilic granular cytoplasm. So you can see why it can mimic a granulomatous tumor because of the pink cytoplasm and the big cells. The individual granules, they are pretty prominent, and the classic feature is you're looking for the pustulo-ovoid bodies of Millian. So these pink inclusions is what you're looking for. Each granule is a lysozyme in its arrested development within a Schwannian cell. So these are S100 and CD68 positive because they have dual histiocytic and Schwannian lineage. But basically Schwannian lineage, the lysozymes, these are the granules. And you can see the nice pustulo-ovoid bodies of Millian. So when you look at big cells with pink cytoplasm or foamy cytoplasm, to go up and look into it. What does it contain? Does it contain just foaminess, which is lipid, which could be xanthoma? Or does it contain, pink cytoplasm, which could be in the xanthogranuloma, reticulohistiocytoma category? Does it contain granularity? Is it a granular cell tumor? Does it contain another example that I'm going to give you, which is a nice mimicker, even though it is a granulomatous process, but it is an infectious process, is lepromatous leprosy. So we talked about and the other one is a better example. We talked about tuberculoid leprosy, and we talked about how tuberculoid leprosy, it presents with the tuberculoid granomas, the bag of worms, where you don't see the organism at all. You, in fact, have to do a PCR analysis on it because even the stains are not useful. This is in contrast to lepromatous leprosy, which presents with an histiocytic infiltrate in the dermis. Very often this disease will also have a Gren zone, but it is not as prominent as what you see in granuloma faciale. But it has a histiocytic infiltrate. But what do the histiocytes have inside them is very different. The histiocytes have these fluffy bacteria in them. So these are called globoid cells. So lepromatous leprosy, you probably don't even need to stain it because you can see the bacteria. Yes, we will obviously stain it. We will do a 5 stain to confirm that these are Mycobacterium leprae organisms, but you can see these globoid cells, these large cells with these fluffy bacteria in it. So looking inside what is there in the cells is important. So this is an example of lepromatous leprosy. I'll show you another example of lepromatous leprosy. This is another one, and you can see here, this one has a much more beautiful Gren zone, and you can see this sheet of histiocytic infiltrate, and this is a nice globoid cell. So you can see this has got these fluffy bacteria inside it. The next common mimicker is a tumor of the benign fat, which is your hibernoma. So a hibernoma is a tumor of the, this is not a hibernoma, I'm sorry, let me show you a hibernoma. Where is it? Here it is. So this is a tumor of the benign brown fat, and it also has the more classic adipocytes, but then it has these larger adipocytes, which will have these kind of pink cytoplasmic webs, like almost looking like spider with multiloculation. And these are your Mulberry cells or spider cells of a hibernoma. So this is a tumor of the brown fat. So that can also mimic a granulomatous entity. The last thing, which is a common mimicker, which is kind of a granulomatous process, but it is a fictitious granulomatous process, is a silicone granuloma. And we'll talk about this later as well when we talk about foreign bodies and stuff. So a silicone granuloma produces a pseudo fat appearance. So the differential that they like to ask you in your board, they will put things like a liposarcoma in there because you may mimic these for lipoblast. But each of this is actually contains silicon in it, and it has dissolved, leaving behind these empty spaces. And they're all variably sized and shaped and associated with granulomatous appearance, inflammation. And this is what is the classic Swiss cheese appearance of a silicon granuloma. So again, markedly variable fatty size spaces, fat-like spaces. It's not truly fat, but they are fat-like spaces. So that would be a silicon granuloma. And then lastly is also a dermatofibroma. So a dermatofibroma, this one is kind of like cellular. The more cellular dermatofibromas get, they often have areas of hemorrhage. When they have hemorrhage, they will have hemosiderin deposition. They can have two-tone giant cells. So like this lesion, it's dark staining, but you can see it has these cells with the two-tone morphology. The presence of hemorrhage and inflammation within the lesion actually favors it to be benign, because the malignant tumors like DFSVs, they don't have. They neither have hemorrhage nor do they have inflammation. So a cellular dermatofibroma or a hemosiderotic dermatofibroma or a xanthomatized dermatofibroma, which has preponderance of giant cells and even fat-containing lipid cells, like for example, like this lesion, they can also mimic granulomatous tumors. But then you look for other things like induction. You look for collagen channel within the lesion. There's beautiful collagen.
We're having a hard time hearing you, Dr. Nod.
No, we can't hear you.
Can you hear me now?
Yes,
Okay, when did you lose me?
right when we told you.
Okay, so not much time ago. So you heard me talking about how DFs can mimic granulomatous processes.
Yes.
Okay. Okay, good. I have addressed this with my IT issue because ever since you guys last week, consistently it has been happening the whole week that suddenly, like in between class, the voice will go and then it will disappear again. So I'll follow up with them if they have, obviously they haven't taken care of it. So I apologize. So let me know if I drop out again. So that was the DF. So these are the mimickers. The mimickers we talked about are your hibernoma, lepromatous leprosy, granular cell tumor, dermatofibroma. Yeah, pretty much those entities. So having said that, now let's go into your study set. So we were going to do, I believe, granulomatous 1, right? Okay, so let's get started. Okay.
And I can start on this one.
Okay.
So I am seeing a very thin epidermis, and I'm also seeing some nodular aggregates of foamy histiocytes. So it's looking like a xanthelasma.
Yes. So why do you think this is the eyelid skin? Everybody knows that.
There's smooth muscle as well.
Yes, there is smooth muscle. But also the thin epidermis and the numerous tiny villous hair follicles. And then you have these foamy xanthomatized histiocytes. And xanthelasma recognition of the skin as the eyelid skin is also really important. So Everybody good with that? Okay, good. Let's go to the next one. Okay. Who wants to take this one?
So for this one, it looks like we have these almost like fist-like balls of histiocytes within the dermis. And there's not a lot of inflammation surrounding them, but there's a lot of shredding of the tissue. And in one of the spaces, I thought I saw like a foreign body. So I was thinking it was a foreign body reaction.
Yeah, so what kind of foreign body reaction?
Like a sarcoidal granulomatous foreign body reaction.
Yes, it's important to specify that because these patients, as I said, who get these kind of reactions to either tattoos or foreign material, they have a sarcoidal diathesis. So it's important for you to know. So first of all, yes, the first recognition is that this is a beautiful sarcoidal granuloma. It's a tight nodular aggregate. You can form a fist pump around it. And then on low power, the location of the lesion, it's like an excisional specimen, right? You said shreds in it. It has areas of dermal fibrosis and scar. This all point to a sarcoidal granulomatous secondary to a foreign body, because in your boards, they'll give you both. They'll give you sarcoidosis and then they will give you that. Sometimes, in nervousness, you may not be able to be like, okay, where is the foreign material? Then use your general sense and common knowledge. It's a big specimen. It's a sarcoidal process located in the deep dermis. It has areas of fibrosis in it. It has shreds and shreds and tears in it. So this has to be a foreign body. And it is much easier to recognize it under the glass microscope because you can polarize it. Here you can't, but you have to look for it. But you can clearly see that there are pieces of this foreign body which would be polarizable and stuck in the tissue. But this is sarcoidal granulomatous dermatitis from a foreign body. Does everybody get that? Okay. Then we have the next one.
I could take this one.
Okay.
So I definitely see a lot of spindle cells, a lot of atypia, kind of pleomorphism, and a butt in the epidermis. So I think this is an AFX.
Yes, so this is a classic example, the beautiful appearance of an AFX. This is how we like to see it. Even though almost always these lesions are cut off at the base. And can you be 100% certain? So I'll ask you some of the second order questions they can ask you with that. So you will answer that, Joshua, okay?
Okay.
So yes, everybody recognizes the histology. It's a tumor that abuts the epidermis arising from it. There is an artifactual cleft beneath it, which just got, I don't know why that has happened. The tumor is just separated off. But you can see the location is classic. There is sun damage. And then when you go up on high power, they're half a arranged fascicles or spindle cells, markedly pleomorphic, ugly, some multinucleated, but this is an AFX. Okay, so the second order questions that they will ask you. First question. On an excision, you see the lesion to have one or more of these features, which require its upgrading to DASH. One or more features include invasion into the fat, perineural invasion.
Yeah. So, sorry, what was the question now? I heard.
The question is, they will show you this slide. Now
Yeah.
they're going to ask you second order questions. Okay, so the answer is not going to be recognizing an AFX, but it's a second order question associated with it, which is classic for your core exams, right? So the second order question is, it's a 70-year-old man with this lesion on the scalp. This is the histology. On excision, on the excision of this lesion, you find basically perineural invasion and invasion to the fat. The lesion now is best classified as DASH.
Oh, okay, gotcha. I didn't understand the DASH part. Yeah, so undifferentiated, like a pleomorphic sarcoma.
Not undifferentiated, it's a pleomorphic dermal sarcoma. So they may also put undifferentiated pleomorphic sarcoma in there along with the pleomorphic. So undifferentiated pleomorphic sarcoma is the other term for a malignant fibrous histiocytoma. Okay, so so that's one step beyond it. That's like when basically those tumors, both pleomorphic in the skin, you want to call them a pleomorphic dermal sarcoma. Lesions which look like AFX, but on excision, the criteria for that is they go into the fat, they go into the deep dermis and the fat, they have foci of necrosis, and they have lymphovascular and or perineural invasion. So if they have any one of these features, you upgrade it. The reason for upgrading it is because these tumors behave like sarcoma, so they need to be followed up because they can metastasize. AFXs will never recur, not metastasize, but those tumors can. Okay, but the correct answer would be a pleomorphic dermal sarcoma. Undifferentiated pleomorphic sarcoma is the other name for a malignant fibrous histiocytoma. Okay, the other question they can ask you on this is the 70-year-old man with this lesion on the scalp with strong staining for smooth muscle actin, negative for desmin. The diagnosis is they give you multiple choices and they also put a polydifferentiated leiomyosarcoma in there. What would you pick? AFX or a leiomyosarcoma? Remember, this lesion is SMA positive.
I don't know the answer to that one.
You will still pick up an AFX. So the
Okay.
non-specific staining is something that they like to test you on. So AFX can show non-specific staining for markers like SMA, ERG, CD10. Okay, so that doesn't make it a leiomyosarcoma, that doesn't make it an angiosarcoma. Okay, so SMA, CD10, and ERG. So those are the second order questions they can ask you. Everybody good with that?
Hmm.
Okay. The next one is your fourth.
I can take this one.
Okay.
Looks like we're on acral skin. I see this pretty like deep central pink red collection of fibrin.
Yeah.
See any mucin. I was leaning toward rheumatoid nodule in this
Yes, that's
case.
great. Renee, is Dr. Guillen with Dr. Jennings?
No, the new doctor?
Yeah.
I have, is with Amanda doing the tour.
He's still down there.
No, he's in our room.
Oh,
She's
he's
showing
still
him
this.
what
Okay,
we do.
yeah, thank you.
You're welcome.
Sorry about that. So yes, so you're right. So you can see this kind of a palisaded infiltrate, and then the central area has this pink fibrinoid necrosis. So even if this location is superficially located, it's fine. It's by the pink geographic area of this pink fibrinoid necrosis that you recognize it to be a rheumatoid nodule. So great job. So this is a rheumatoid nodule. Everybody gets that? Good. We have the next one, which is the fifth one.
So here we can see the swollen collagen bundles in the dermis, and on the right side of the slide, you can see it's palisaded around like dead stuff there. So, GA.
Yeah, it's GA. So GA is one diagnosis which can be very subtle. So if you're looking at GA, it's good to look at all the levels. This one, the bottommost level, which is your third level, it's the most predominant. And you can see here it is an interstitial infiltrate of lymphocytes and histiocytes, which are wrapping up around these swollen collagen bundles. So there are no discrete areas of necrobiosis, but the individual collagen bundles, they are swollen. So this is what is referred to as the interstitial variant of GA. Yes, and it's best recognized on low power. Good. Everybody good with that? Okay. We have the next one, which is the slide 6.
I can take this one.
Okay.
So we have areas of both light pink, or the pink, which are histiocytes, and the dark blue, which are lymphocytes. And so I called this Rosei Dorfman, and if you look in the pink, you should be able to see some
Okay.
cells.
What do you think this cell is right here?
The arrow.
This one.
I would maybe
Okay.
a Teuton giant cell.
What is it?
A giant cell. It looks very
Yep, it's a giant cell. What kind of giant cell?
Teuton.
Yeah, it's a two-ton giant cell. Where do you see two-ton giant cells?
A few things, xanthogranuloma, xanthelasma, or xanthoma, arcoid maybe.
Yep. So it's pretty, it's a pretty, here's another one. You see that? This is a better one. You see that?
Yeah. Okay. Mm-hmm.
See the ring of nucleus, the dense pink cytoplasm, and then the xanthomatized cytoplasm around it.
Yeah.
So this is a xanthogranuloma. So you know, when the architecture of the lesion. So I'll go through with what you saw. So how many people, that's fine. It's great that you thought that. How many people thought this to be Rosai-Dorfman? Okay. Okay. So whoever thought it to be Rosai-Dorfman, explain me where you thought was emperipoiesis. The alternating blue and the pink. Yes, there are some blue areas in here, but it's predominantly pink, as you can see in here. Right? Okay.
Yeah.
So even if you thought that, let's go up higher on these pink areas. I think here.
I was thinking maybe the like
Like
in
these
giant
cells here?
the small blue nuclei were like the emperiopoiesis. Like
Okay, so in Rosai-Dorfman, when you go up on higher on the pink areas, the individual histiocytes are actually not multinucleated. The individual histiocytes, they form like a C-like syncytial aggregate. So they form like a network. Okay, here you see those pink cells. This is one big giant cell. There is another one big giant cell. There's another one big giant cell. This is another one here. It's another one here. And its cytoplasm actually looks pretty empty. You see that? And it's starting to get this kind of foaminess, which is because it is eventually going to form the most mature cell, which is a xanthogranuloma. That's why most often the two-ton cells, they're random, they're scattered around, right? And see now here it starts acquiring. Here it is another nice one. You see that?
yep. Mm-hmm.
So in Rosai-Dorfman, A, you don't get multinucleated cells. B, the zonation that we talked about is pretty distinct. Okay, so this is a xanthogranuloma. Now everybody gets that?
I have a question, Dr.
Yeah.
Anand. And I thought it was a reticulohistiocytoma. Only
Okay.
because I thought I could see maybe like some two-toned cells or cytoplasm, excuse me. I'm wondering though if that's just artifact.
That
Starting to think
is
that. Okay.
yes.
Just needed
And also in a
clarification there.
reticular, it's in a so that is a true diagnostic challenge which everybody faces. Okay, when we come across a xanthogranuloma like lesion, we always think, is it a xanthogranuloma or reticulohistiocytoma? Most often it is actually a xanthogranuloma. The reason being, xanthogranuloma is the one that goes through the varying stages. So the degree of the two-ton giant cells and the lipidized histiocytes may not be that prominent. That is why you can have early inflammatory proliferated JXGs if you have heard those names. Okay. Whereas a reticulohistiocytoma is, when you see it, you recognize it because all the cells, they have this, and they're not very multinucleated. They may be binucleated. What stands out is the denseness of the cytoplasm, and you never have this foaminess in it. This slide, unfortunately, the problem with this slide, I tell you, is that the tech who basically cut it, he didn't do a great job because there are shreds and pieces in here which kind of distracts you. So it's just kind of like an annoying slide, and I agree with that. But it has the diagnostic features which are pretty recognizable. And I still decided to leave this in there because it always incites that kind of a response from you, which I like. So, but now does everybody see? Were you able to see the two-ton giant cells? So the bottom line is that the two-ton giant cells, if you see xanthogranuloma in a differential, make sure that you're looking around. Superficial areas are the good place to look around. This is another two-ton giant cell right here. Okay, and the other thing is, if they don't have a xanthogranuloma in there, they can have mimickers of xanthogranuloma. So entities which look like xanthogranulomas, which are Xanthoma disseminatum, benign cephalic histiocytosis, progressive nodular histiocytosis, generalized eruptive histiocytoma. Remember, I gave you the list of the conditions which could be more systemic. It's there in your handout. So they could have any one of them in there. Xanthoma disseminatum is the most common one because then they can ask you a second order question with it because it's associated with Waldenstrom's, with the paraproteinemia, middle-aged elderly man with CNS involvement, hoarseness of voice, epilepsy because of meningeal involvement and cutaneous lesions. Everybody good with that? Okay. Let's go to the next one, which is your slide 7.
I can do this one.
Okay.
I thought we had kind of what we call tabling of the epidermis. And then you have a lot of spindle cells in here, and there's some collagen trapping you can see well at the periphery.
Yes.
And then there is some hemosiderin, I think, in like the bottom. Yeah, they're over there.
Yep.
And so I thought this was a dermatofibroma.
So this is a beautiful example of a hemosiderotic dermatofibroma where you see the nice collagen trapping. It starts getting cellular, but it has the hemorrhage and all this pigment in it, which is a hemosiderin pigment. So this is a beautiful dermatofibroma. Good job. 7th, and then we have the next one, which is the 8th. Hey.
There we have kind of the layers of a cake. It's involving the entire width and depth of the biopsy, and it's the sclerotic collagen, so NLD.
Yeah, so this is NLD. So we have you have the nice layers of a cake. This is a classic biopsy. It involves the breadth and the depth of the biopsy. And you see the nice palisated grandomas with the layering of the cake. The cream of the cake is a beautiful sclerotic collagen. And often at the junction of the dermis and the subcutaneous tissue, you'll be able to see, often you see, plasma cells at the leading edge of the biopsy. So that is NLD. Everybody good with that? Okay. And remember that the later the lesion gets, what will it mimic? The older the NLD gets, what will it mimic?
Morphia.
Morphia. Because the inflammation will subside, but the sclerotic collagen will remain. And you can see how it will give you the nice squared off effect. But then if you see any remnant of a granulomatous infiltrate, it's NLD, it's not morphia. Okay. The next one is slide number 9. Okay.
I can take this one. So
Okay.
they just look like poorly formed granulomas, like tuberculoid granulomas. Don't necessarily see like it tracking along nerves like leprosy would. So it's kind of in between just tubercular granuloma versus like tubercular leprosy.
Okay, so for a tuberculoid granuloma, so this entire process is pretty much just located here, right? You see that?
Yeah.
Typically, tuberculoid granulomas, they track down. And then when you go up on high power, so you see there is a busyness here, right? So this is where I want to go on high power. You agree with that? This is where you would want to go up?
Yeah.
Okay. When you go up on there in the high power, what are these cells?
Histiocytes.
Histiocytes. And what do you think they have in them?
It's maybe lipid.
Exactly. It is lipid. When you think that histiocytes have maybe lipid in them, you're dealing with an eruptive xanthoma.
Oh, okay.
So eruptive xanthoma is like gut hysteresis, like the primitive form, right? Like, right, your triglyceride level go up and the patient erupts. So these are the least well-formed xanthomas. Okay, they're the least well-formed. So always on low power, you will get something that looks busy in the dermis. So you think about things like GA or random thoughts, you really don't know. And when you go up on high power, the lipid is not that prominent as what you would see in your other case. It may be prominent, but most often it is not. And what you see is, but they're all one kind of cells. After you recognize it to be lipid, do you see that every cell is the same? It all has lipid in its varying stages.
Yeah.
So that is an eruptive xanthoma. It can also have cholesterol phleps. Remember, it's in its primitive form. It can do that. But most often, this is how it will look like. It will look more pink, but when you pay attention, it does have lipid in it.
Got it.
Okay, and if the cells have lipid, then they cannot be tuberculoid, right? They cannot be tuberculoid granulomas. So everybody good with this? Let's go to the next one, which is the 10th one. This probably belongs in the next category in a couple of classes. That what we're doing is going to be like your exogenous kind of stuff, but I still decided to leave it in there. The main thing is recognition of this, and what is that?
Like a splinter.
It's a splinter. And the other thing is not to get confused with this. You see this? You'll be very quick to jump to a squamous cell in here, but you can see this is all reactive pseudoepitheliomatous hyperplasia because of this. It's not uncommon that a splinter most often comes in at SCC.
We're
think your
losing your
microphone
audio
is-
again.
Can you listen? Did you listen now?
It's a tiny bit better, but you're still mumbled.
Any better now?
Yeah.
There we
Okay.
go.
Okay, let's do the 11th one.
Yeah, I can take this one.
Okay.
Oh, Kendrick, take it away. Sorry.
This is kind of like the columns on fire that you described. So this is like the verruciform xanthoma.
Yep. Yep. And then the second order question, name like one disease it can be associated with.
Trying to remember. Oh, the child syndrome.
Yes, yeah, there are multiple, I think, and then they also give examples like epidermolysis bullosa, right? The inherited ones. And even discoid lupus because of though I've never seen it in association with discoid lupus, but I think Mickey or one of the books gives those associations. Yeah, so that's verruciform xanthoma. I think everybody should have gotten that one. Let's go to the next one, which is just slide 12.
I can take this one.
Okay.
So we see tattoo pigment kind of deep, and then we see these like really nice naked, well-formed granulomas. And so we can use sarcoidal reaction secondary to tattoo.
Yeah, good. So sarcoidal granuloma from a tattoo. And it's important again. This is one thing which really ticks me off when people mention, oh yeah, this is tattoo reaction. No, you have to mention it's a sarcoidal granulomatous tattoo reaction because that has a specific implication. So you do need to mention that it's sarcoidal granuloma from the tattoo, which is very obvious in here. Good. The next one is 13th.
I can take this one.
I actually wanted you to take this one.
Perfect.
Good. Yeah.
I saw like some purple histiocytes in like a punched out lacunae with the two-tone cytoplasm, and then occasionally some bi or multinucleated cells. So I call this the reticulohistiocytoma.
Yes. Now, does everybody see the difference between this versus the xanthogranuloma? When you see a reticulohistiocytoma, you will know it. If you're getting confused between a reticulohistiocytoma and a xanthogranuloma, you're dealing with the xanthogranuloma. Okay, these have very nice, and they are not really multinucleated. They are more like binucleated. Maybe they may have like 3 nuclei, but they're not like big multinucleated like the xanthogandoma. And then this is the nice dense amphiphilic cytoplasm. Yeah, that's your reticular histiocytoma. And then plenty of second order questions, right? Multicentric reticular histiocytosis, paraneoplastic manifestations, association with autoimmune disease, progressive destructive arthropathy. There's so many questions they can ask you. So a lot to know theoretically. Okay, next one, so slide number 14.
I can take this one.
Okay.
I could see like some interstitial histiocytes and potentially some mucin and eos in here. So I was leaning toward interstitial GA.
Yep, so this is GA. And this is the one on low power. Like when you look at low power, this is how also eruptive xanthomas will look. You remember that slide of the eruptive xanthoma? It was busyness in there. So the low power of eruptive xanthoma always reminds me of GA. But when you go up on high power, this is clearly, there are no foamy histiocytes. So this is GA. Good. Okay.
So this one, we have a big nodule in the dermis, and when we zoom in on the cells, we can see that they're very, very grainy. And next to them, they have these pink dots or the pustule-ovoid bodies. So I was thinking granular cell tumor.
Yeah. So you see on low power, honestly, this looks like a xanthoma, doesn't it? Big nodule, multinodule. But when you go up, so that's why you have to go up on high power. And when you go up on high power, you clearly see that these cells have granules in them. And here are the pustulo-ovoid bodies. There's another one right there. So this is your granular cell tumor. And then they can ask you again, number of questions. These are Schwannian cells. They are S100 positive. And these granules are the lysozyme. So this is a granular cell tumor. And you can see these nice pustulo-ovoid bodies. Okay. Everybody good with that? Okay. 15, next one to 16.
So here you can see this infiltrate of cells involving the superficial dermis and the epidermis. When you zoom in, you can see the kidney bean shaped cell, so Langerhans cell histiocytosis.
Yeah. So you can see the nice, this is beautiful morphology of the Langerhans cell. The location is classic, epidermotropic, epidermal infiltrate, little bit going on into the dermis. When you go up on high power, you see these cells with the nice nucleic grooves and indentations. So these are all, which markers will it be positive for?
CD1A, S100, and Langerhans.
Yep. And what do they have on electron microscopy?
The Burbeck granules.
The Burbeck granules. So this is Langerhans cell histiocytosis. Now Hashimoto-Pritzker disease, which is your congenital self-healing reticular histiocytosis, would also look similar. So yeah. So does everybody get that? All good? So you know all your second order questions, the Burbeck granules, the CD1A, S100, Langerhans, are the mimickers of the same entity, which would be the self-resolving variant of it, which is the Hashimoto-Pritzker. So they all will look similar. Okay, good. Let's go to the next one, which is your slide 17. So the 17th slide, again, this is like the splinter. I'm going to tell you about this slide because this completely doesn't belong in this category, though it illustrates to you the fact that sometimes, things like GA or, necrobiosis or even suppurated granuloma, because if you look at it, how many of you thought this is caseation, necrosis, and infectious? Right? It looks necrotic. This is what necrosis looks like. And this would be the kind of a case where you would be like, oh, I have to work it up because it is infectious. And then suddenly you notice again these shreds and spaces in the tissue. These are very consequential when you're seeing a granulomatous lesion. Things like holes and spaces is what you should pay your attention to because they may be hiding something where the answer is really obvious. And then when you go into all the levels, these are true holes and spaces. You see how the piece of the tissue is like broken apart. And then there's actually a foreign body stuck in here. And there is a really obvious foreign body in one of these places here. So, when the foreign body gets gets stuck in the tissue, essentially in my head, there are like 4 kinds. The 4 kinds of foreign materials that you see, in broad category, they could be polarizable or they could be non-polarizable. But the 4 kind of foreign bodies you generally see is either they are like Orbis status. Second thing is there's Orbis glass, like silica, like what I showed you previously, which produces the classic sarcoidal granulomatous reaction. Or it is a foreign body which has a combination of something that contains carbon or iron, or it just contains carbon or it just contains iron. So it means it's either black or it is brown. Okay. If it is black, it's a foreign body which has carbon-like material in it. If it is brown, it has a foreign body which has something like metallic iron in it. Sometimes it will have both. It will have both black and it will both have brown. Now, why am I talking about this nonsensical stuff? Because honestly, this is very frequently encountered. Okay, so if you know these in general facts, it is easier for you to deal with, oh yeah, this is a foreign body. So this is a very common kind of a foreign body that we see, which looks like crystalline iron. So the way I would sign this out is this is a foreign body granulomatous reaction, which has features of a metallic substance which contains iron. Okay, and when you see this, then you can explain, oh yeah, this GA-like process or this pseudo-palisaded process or this something which looks infectious is because of the foreign body. There is an easy explainable cause for it. So you don't need to go down the infectious route. That was the purpose of this slide. Does everybody get that? Okay. Let's go to the next one, which is just slide 18. Okay. It's a really nice slide. It's like one of my favorite slides because you deal with this a lot.
I can take this one.
Okay.
So we have a lot of aggregates kind of around blood vessels and anexa, and then I zoomed in on them, and there's a lot of plasma cells. So I thought this was syphilis.
Yes, but you notice how tuberculoid they are?
Yeah, that was like, I put that first and then I zoomed in.
Then you zoomed in, exactly. So, was it Arman that who missed that for the tuberculoid? Do you see the difference?
Yes.
You see the difference now?
Yeah.
That, so you see how like it is oriented perpendicular and the infiltrate is much more deeper and it's much more nodular than poorly defined. The reason it is nodular is because it is growing around vessels. And that's when you think about tuberculoid granuloma. And then the second step you have to do is the 2 things which can do this on low power is tuberculoid leprosy or syphilis. And then you go up on high power and you look for plasma cells, and that's syphilis. Okay. And we are seeing a lot of syphilis. Like it's rampant in the state of Georgia. I don't know about what's happening in your state, but it's rampant in Georgia. Like we are seeing almost like 4 to 5 cases of syphilis a month, and I'm not exaggerating it. So this is secondary syphilis. Okay. We go back on 19th.
I can take this one.
Okay.
So there's they look like naked granulomas there in the dermis, sort of sarcoidal. I didn't see any foreign bodies. There could have been, but I didn't see any. And so I was sort of favoring sarcoid.
Yes. So, this is the kind where your probability of finding a foreign body is going to be very low because you see the kind of punch this would have been done for a sarcoidal lesion. Most often when you get the sarcoidal granulomatous form of foreign body, you're not thinking sarcoidosis. It actually presents like a bulky lesion where you are thinking a cyst or you're thinking something different. So it ends up in an excisional biopsy. So most often those are bigger biopsies. Okay, this looks like it would be a tiny punch into a nodule. The location is good, right? Most of the sarcoidal granulomas are either like lichenoid or they are superficial and mid-dermal perivascular. So the location is also good. And then you see the nice type. So these are the ones where you can be quick in deciding, I don't see any foreign body, and this would be sarcoidosis. Good. Next one is this one. Hey,
I can take this one.
okay, Taylor.
So here, I thought that this looked like a tuberculoid granuloma. And there were some pilosebaceous glands. And then so because of that, I was thinking of granulomatous rosacea.
This is beautiful granulomatous rosacea, and you even have a Demodex mite in here. You see that?
Yes.
The Demodex mite. So this is granulomatous rosacea, and this is not a very important board question, but they may ask you. But it is a very practical question because we get biopsies of this all the time, and this is how it looks like. So it is the face. You see the pilosebaceous units. You see all the vascular telangiectasia. You see the numerous telangiectatic vessels, and you see these granulomas, which could be variable, but most often they are tuberculoid. Sometimes they can be sarcoidal as well. And they have this like kind of a sprinkle of neutrophils in them. Remember, because neutrophils are important in rosacea. So, you will get neutrophils. And then on top of it, if I always like whenever I'm diagnosing rosacea, I try to look for the Demodex mites because it gives them some reason to treat as well. So it's nice to document Demodex mites in rosacea, and it slam dunks the diagnosis. Like for example, in sebderm, I try to look for Petrosporus spores because that would be a conclusive evidence of that. So yes, so this is a nice example of granulomatous rosacea. Good. And the next one, which is 21. So this one again, I didn't cover with you guys, but it is important in this as well. But we will talk about it when we do iatrogenic stuff as well. So how do you describe this? These are slit-like spaces, right? So when you see slit-like spaces with giant cells, everybody recognizes that, right? So when you see slit-like spaces with giant cells, you think about three things that can happen. Those slit-like spaces can contain a keratin, can contain cholesterol, or they can contain a foreign body. Okay? So if along with the multinucleated giant cells, you see these slit-like spaces, and if they contain keratin, which is like here, it is a keratin granuloma, which could be a ruptured cyst or a follicle. If along with the giant cells, you contain the slit-like spaces, but they have fat in them, which is cholesterol, then it's a xanthoma, cholesterol clefts of a xanthoma. If along with the slit-like spaces, you have some keratin, but you also have recognizable foreign body, that is your polyl lactic acid, which is your Sculptra or Neufil. So Sculptra or Neufil on low power really looks like a keratin granuloma. It really looks like a ruptured cyst. But when you go up on high power, these slit-like spaces besides keratin have the foreign body. We will do this in detail again when we are doing the foreign bodies, but I just want you to remember that this particular instance is of a keratin granuloma. Is that good for everybody? Good. So remember those three things when you think about the slit-like spaces. This is the next one, 22. So a classic example. Okay.
So we have this caseous necrosis surrounding the hair follicle, another slide. So lupus miliaris.
Yes, so you see this one large giant palisaded granuloma with central caseation necrosis, and you can see it is in the path of a follicle. So this is beautiful for acne adminata or lupus miliaris disseminatus fascia. This is how it always looks like. If anybody didn't get that, I want you to pay attention to it. Is everybody good with it? One large giant granuloma with the central caseation necrosis in it. So that is your lupus miliaris disseminatus fascia. This is a really important board question. Much more important than granulomatous rosacea. This is almost a certainty to be there on your boards. You see one large granuloma with central necrosis, which is folliculocentric. And in this case, it is nicely folliculocentric, but this may not always be the case. You may not always see the follicle, so you may just see this half of the biopsy. but you can see it's one large with the central necrosis. So you presume it to be around the hair follicle. Okay, good. Okay, 23. So now you will understand the relevance of this. What is this?
I can go for this one. I saw a lot of spiderweb cells and the bright red mulberry inclusions. So this is a hibernoma.
Yeah. I think if you've seen it once, you'll always remember it. I think everybody should have been good with it. This is a hibernoma. Good. 24.
I can take this one.
Good.
Here, I just saw a lot of cells that are kind of lining up in between the collagen bundles in a row. And I also thought I saw some signet ring cells in there too in places. So I was thinking this was metastatic breast.
Yep. Yep. And yep, you can see in here, it's metastatic breast cancer. I'll be teaching you about metastatic breast cancer at least like during 3 different instances during the course of the year. But that's how important this slide is. Like, it's going to be there on your boards. Metastatic breast cancer, leukemia, cutis, both of them are going to be there. You have to get used to recognizing it. And this is beautiful for metastatic breast cancer. You see the nice single cells lining up, and you see the intranuclear cytoplasmic vacuoles, which are your signet ring cells. So that is breast cancer. Everybody good with that? Good. And why do I put it in here? Because, you see low power, it can look like GA, right? You can easily mistake it for busyness, and if you're in a hurry and the clinician has not thought about it, you'll misdiagnose it. You will think it's GA. That is the reason. We have the next one. Okay. It's a classic example of
Sarcoidosis.
sarcoidosis. This is as perfect it can get for sarcoidosis. This is how the classic sarcoidal granulomas are. First of all, it's a dark-skinned patient. Second of all, it's a lichenoid distribution. So you see how they abut the epidermis but not destructive. And nothing can be more sarcoidal than that. So that is perfect for cutaneous sarcoidosis. Good. The next one, 26. Okay. So in this scenario, I want you to describe what you're seeing and what your thought process is. So who is ready for the challenge?
So I think you see
Good.
maybe a pseudo-palisading granuloma, central necrosis, but there's this spaces are different sizes. Just thinking like a foreign body, like a silica or
Okay.
suture or something.
So I really like the fact that you described this to be pseudopalisading, because it truly is pseudopalisaded. That's a beautiful word. That's a word of a dermatopathologist that you use. So that's really nice. Does everybody get that appearance? What Arman described, it's pseudopalisaded. It's not palisaded truly, right? Because if you think it's palisaded truly, then you start thinking about GA, NLD, and rheumatoid nodule, and you go down the wrong path. So it's a pseudopalisaded infiltrate. So what are the things that can give you the pseudopalisaded infiltrate? You talked about a foreign body, which is good. We just saw in the previous example I showed you guys, there was a pseudopalisaded infiltrate, which turned out to be a foreign body. What else do you think about a pseudopalisaded infiltrate, especially looking at the composition of these cells?
Like a paraphenoma.
Okay, so let's club that into a foreign body, right? Because a paraphenoma is a foreign body. And a paraphenoma actually doesn't really, like, a paraphenoma is a specific kind of a foreign body where the features are very subtle actually. It looks like, and we'll talk about it more when we do a foreign body, more than inside, it doesn't incite a really necrotic response. It's subtle. It's a foreign body which is quiescently sitting out there, which is not like really damaging the skin, but it is there. Okay, so foreign body is one, so you definitely would polarize it. But what are these that you're seeing over here?
Oh, giant cells.
Yep, they are giant cells. And then what are you seeing in over here? What are these cells?
There's some newts, I think, are on there. So
Yeah, there are lots of newts, right?
infection.
And then how do you describe this? Like, what is this? Like, is this living tissue or dead?
Dead.
It's dead. It's necrotic.
We're also sorry, we're losing your audio now again. No.
You hear me now?
A little bit more.
Okay, so I'll be back in a minute.
Yeah, I think we're good.
Okay, good. So, so we were talking about neutrophils, right? And we were talking about this is dead tissue. And does it look like healthy dead? Like it's like everything dead is bad, but this looks like it was creamed up and died, right? Like it looks really dirty. This is called dirty caseation necrosis. When you see this kind of neutrophils mixed with this necrotic tissue, this feature right here, where you see the pseudo-palisaded nature with the granulomas, which are the histiocytes, and the neutrophils, with this dirty caseation necrosis, that is in the category of a suppurative granuloma, which should make you think about an infection. Can everybody get to that, what I said? This is when you start worrying about an infection. These features should make you worry about an infection. You see all this necrosis? You see how this neutrophil debris is there with the necrosis and the suppuration and the granulomas and the necrotic stuff. That's what makes you think about infectious. Is everybody on the same page right now? Arman, you're not on the same page. Something is bothering you. What is bothering you?
No, I agree. Sorry.
Okay, you do agree. Okay.
Taking minutes. Yeah.
Okay, so everybody agrees this is infectious. So now the next question is either you see the infection or you don't see the infection. So in this kind of an infectious process, what are the organisms that will do that? Number first, Miyawki's granuloma can do that. Okay, which you will see in infected hair follicles, which I don't. But if I spent like more than a minute, we will not have more than a minute. But if you're not able to see it instantaneously, you don't see it. Okay. The next infectious organisms that can basically do that are things like Leish, Histo, Blasto, Coccidio, Paracoccidio, which we'll cover. So like you will see the organisms, which I'm not seeing the organisms. If you don't see all those organisms, then what else can do that? That's mycobacterial and atypical mycobacterial organisms. So you will not see the organisms in that case, right? And the only way to see that organisms is by doing an acid-fast and a fight stain and by culturing it. Okay, so what are the questions they can ask you? They can ask you multiple second order questions. They show you the slide and they can ask you referring to any one of the things that I've talked about. What are your next steps? Yes, you're going to look for a foreign body, but most importantly, you're going to do an infectious workup. Your infectious workup would include markers like PAS, GMS for fungus, acid fast, and fight. The least important would be to do a gram stain because classic bacteria like a furuncle doesn't produce this dirty necrosis. So you typically don't think staph doing this. It generally produces you an abscess. That's the least likely that you're going to do, but the others you will have to do it. Okay. If you cannot see any organism, then they can ask you about culture. What would be your next step? You would do tissue culture. Can you culture this slide that you have gotten? Answer would be no. You have to do a fresh tissue culture. So you'll have to go back, do a biopsy, put it in normal saline, which would be the most normal thing to do, or in a wet gauze, and you send it to the lab. It has to be a fresh piece of tissue. You still cannot grow the organism. The next step would be you PCR. You do a PCR analysis again on fresh tissue is what you would prefer. Other questions they can ask you is, most likely organism to cause this. If you're not seeing it, it's mycobacteria or atypical mycobacteria. So it could either be tuberculosis, it could be things like scrophaloderma, or it could be Burulli's ulcer, which is Mycobacterium ulcerans. It could be a swimming pool fish tank granuloma, Mycobacterium marinum. The most common is Mycobacterium chelonia and fortunatum. Those are the most common ones that produce skin infection following wound contamination. That's how they get into your skin. Very unlikely Mycobacterium kansasi unless and until the patient is immunocompromised, and almost never Mycobacterium avium unless and until like the patient has florid HIV. So those are the plenty of second order questions they can ask you. So the bottom line is to recognize the reaction pattern in this. And the reaction pattern is a suppurative granulomatous dermatitis suggestive of an infectious process. Did you get all that? So this is a really important slide. So go back to it. This is classic. If you see this, I hate to see these slides because it means so much of work for me, right? Like I have to work so much on this, formulating a question, talking to you guys, talking to the clinician, and getting so many stains orders. So this is a pain in the neck biopsy, but it's important. And we do deal with this quite a lot. Okay, the next one. That is the same kind of dirty necrosis that you will see in erythema induratum. So next week when we talk about paniculitis, no, maybe the following week, when we talk about paniculitis, you will see that's the same dirty necrosis that you look in the fat for E. induratum. Okay, slide 27.
I can go for this one.
Okay.
I see a lot of pink blue aggregates growing perpendicular to the dermis. So I was thinking it didn't have any plasma cells, so I'm not thinking that it's a syphilis. It was looking more of perineural invasion, so I'm thinking it's a tuberculoid granuloma.
Okay, tubercular granuloma, and then what is this?
That is a nerve.
That's a nerve with a giant cell right next to it. So that's perineural inflammation. That's very, very suggestive of tuberculoid leprosy. Does everybody get that? Good. Then you have the next one. You're never going to see the organism in there. So what would be your next step in that? You would, yes, the next step would be to do a Phyte stain, but after the Phyte stain, what would be the next step? Should I culture that lesion?
Get a tissue culture.
Nope. If you're thinking about leprosy, forget about it.
PCR.
It's going to be PCR. You cannot culture Mycobacterium leprae. It's extremely difficult. You have to do PCR, and the PCR need not be on you don't need fresh tissue PCR. You can do it on the block. So you can call up the pathologist and tell them, please send it for PCR, and the PCR is free. You can send it to CDC. You can send it to the National Hansen's Disease Center in Louisiana. So it is free. So you can easily send it. Okay, the next one, 28th. This is the blue and the pink alternating. Now everybody sees this, right? This is the blue and the pink alternating. And when I go up higher on the pink areas, do I see any multinucleated cells? No, I don't see it, because these are individual large histiocytes which are forming a syncytial network. They're holding hands. So it's like a sea of histiocytes. And this is the histiocytic nucleus because it's lighter and larger. And floating in its cytoplasm, you see these other cells, the darker cells? And there are plasma cells right adjacent to it. That's like diagnostic of Rosai-Dorfman. And these cells, these areas will be S100 positive. Now you see the difference between this and the xanthogranuloma? So that's cutaneous Rosai-Dorfman disease. And these will be S100 positive and CD1A negative. Okay, 29th. Who wants to take this one?
We have a deep dermal capsule on acral skin. It's very well circumscribed. And if you zoom in, you can see kind of some cholesterol clefts and foamy histiocytes. So tendinous xanthoma.
Tuberous or tendinous xanthoma. So tuberous tendinous xanthoma, they're classic, right? On the you often see them, the thick skin biopsies, the elbows or the knees, or not really the knees, but the you get the point. The older they get, they will develop these fibrous septae and they will have this multinodular appearance. And when you go up on high power, you see the nice foamy xanthomatized cells. So they can mimic granular cell tumor. That's why you have to look inside the cells, like what are they made up of? And you can see the nice foaminess of the cytoplasm. So this is a tuberous or a tendinous xanthoma. Good. And then the last one also really doesn't belong in here. This is a classic example of a spitting suture. It's again in the foreign body section we will talk about. Random pieces of skin. And then you have to be careful in looking at what is being extruded out. And this is the suture material here. So this is a spitting suture. Okay, so now in the next class, I'm going to teach you vascular diseases. There's not a whole lot in vascular diseases, so it's not going to take up my whole class. So after I do my vascular diseases, I would like to, I'll give you guys the option. Do you want to go through the granulomatous set 2, which I think we should, because I don't think so you guys have hammered the granulomatous diseases that well in your brain. So let's do the granulomatous study set 2, and I'll teach you guys vascular diseases. Does that sound like a plan? Everybody has granulomatous set 2? You guys have that. Okay, so vascular disease and granulomatous set 2. And I hope somebody is writing that because I'm going to forget. Okay, so that's what we are going to do next time. And then I am thinking that after that, I'm going to be a little mean. I want to give you guys a test covering the topics that we have done. So we have covered spongiodic psoriasiform interface, blistering, granulomatous, and we'll be covering up vascular diseases. So we can either finish paniculitis and then we can do the test, or we can do it after the vascular diseases. But I think we have studied a lot of inflammatory entity that it's time for you guys to take a pause and to go back and to revise everything that you have done before we move along. So are you guys up for that? So we will plan tentatively for not the next week, but the following week. But then we'll see how, I'll see how you guys are doing next week. If you want to stretch on to the paniculitis, and we'll do that, and then we'll take it in 2 weeks from now. Okay?
Can you tell us what you mean by test, like just unknowns you do?
So no, so the test would be, I will give you, it will be like of your core.
Okay.
So I will give you like a test booklet with, you know, the Goodman residents have done that before. So I will give you like a test booklet, which will basically all mostly be second order questions because that's what your core does. So you have to, it will be a timed test. So what I will do is like on Friday, I will around this time, I will tell Anthony to release it into your this thing. And then you will get the booklet, and then you will have the test. And we will give you a specific amount of time for answering those questions. You will take the test, and you know, once the time is over, you will lose access to that. Okay, so that it will be a true time test, which will give you under the pressure of looking at the slides. And it's just for learning purposes. You know, it's not a GPA oriented test. So, okay, so it's just for you guys, just for learning, so that you get used to that, looking at slides under that pressure that you have to answer a second order question and you're looking at it and you feel confident that you're doing that. And we'll discuss the answers all together, but you know, I'll also individually kind of get to know how all of you guys are doing. So it will give me more of a, if I need to work with some of you more, then I will. Okay, does that sound like a plan? Okay. Sounds good. So we will meet next week, and vascular and granulomatous 2 is our game plan.
Sounds good. Thank you.
Thank you.
Thank you. Weekend.
You too.
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 Yeah. Bye.